Hey guys, welcome back and welcome to the EKG Guy if this is your first time. This is our third week of the EKG of the week, and we've got really good feedback, so I hope you're really enjoying this. I think it really helps when we take the time to actually go through these properly and not to miss anything, okay? So for those that are new, what we're doing is using this approach to the EKGs, and it's worked so far, and we're going to continue as we keep doing these each week, see if we have to improve it, okay? So let's just go over that. Well, what you see here is the patient information, okay? Below you have the EKG. And on the right side, you see the things that we're trying to address. Okay, we start with regularity. That means, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular, like we see in sinus arrhythmia, or is it irregularly irregular, as you would see as, such as AFib or atrial fibrillation? Next, we look at the heart rate, okay? So simply determine the heart rate, then we look at the rhythm origin. That is, where is the rhythm actually starting from within the heart? Then there's the atrial AV, or atrioventricular, and then intraventricular, or IV conduction. And here we're looking, is the conduction normal, okay? Is there prolonged QRS or PR interval, or even P wave here, okay? Then we'll look at the waveforms. That includes all the waves, the segments, and the intervals. And lastly, we look at, is there anything else? Meaning, is there something that we missed or forgot to mention, okay? And after that, we use all this information to make a final interpretation, okay? So let's get started. Our patient this week is a 21-year-old healthy male student that comes to us at our outpatient clinic with this EKG. Pause the video and take a few minutes to go through everything we discussed and try to fill that out yourself on a piece of paper. When you're ready, start the video and we'll go over it together. Okay, so we have our 21-year-old healthy male student comes to us at our outpatient clinic and he has this EKG. So what is our regularity or of this rhythm here? Okay, so that's the first thing we're looking at. On first impression of this EKG, you probably notice that the rhythm appears quite regular. Okay, in fact, this is a regular rhythm. Okay, so how do we know that? Well, what we do is look at the R to R intervals. That's usually the easiest to do. So you look at, say, this R to this R, that's the R to R interval, and then you would compare the next R to R interval. So we would look at the one that follows. So for instance, this to the next one and look at that interval. And if you were to draw or use your calipers and measure all those R to R intervals across, okay, all the way up until some of these last ones, you would notice that the length or the duration between them all is the same, okay? And because we have that, that's what we mean by having a regular rhythm, okay? You have these beats that are coming at predictable times, and that's what we mean by regular, okay? So what did you get for the heart rate? Well, there's a couple ways we can figure that out here because we're dealing with a regular rhythm, okay? So one of the ways you can do is by knowing that the duration of this whole EKG represents 10 seconds. And if you multiply that by 6, we get 60 seconds. Okay, that means if we count the number of complexes going across the whole EKG, multiply by 6, we can have a good idea of what the rate is here. Okay, so I'll give you the actual rate here was 57 beats per minute. Okay, so if we count these now going across to see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, so we would do 10 multiplied by 6, okay, and that gives us 60 beats per minute. So pretty close approximation, okay, to that 57. Now, there's also another way that we can find it out, okay, so you can use this approach where you multiply by 6 and count those complexes with irregular rhythms, okay. Now, one other way we can do it with these regular rhythms is by, let's erase some of this stuff here. Okay, so what we will do is take this R wave, okay, and we'll count or look for the next R wave that comes up next, okay? And it's a little hard to see, but you can somewhat make out those thick lines. We're going to count the number of thick lines from one R wave to the next. So there's 1, 2, 3, 4, 5, okay? So about 5. And what you do here is 300 over 5 gives us 60 beats per minute, okay? So you're taking 300 and you're dividing it by the number of thick lines, and that gives us 60, okay? Again, pretty close to that 57. That is the actual rate, okay? So again, regular rhythm so far, and then our rate is 57 beats per minute, okay? That's the actual one. Now, how about the rhythm origin? Well, we have narrow QRS complexes, okay? This is our QRS. All right, it's narrow, so that means we're likely dealing with a supraventricular rhythm, meaning it's coming from above the ventricles. We can also make out some P waves, nearly isoelectric, but they are there if you look close enough. So are we dealing with sinus rhythm? Okay, so let's look at here. So remember, when we look at sinus rhythm, we know that if you imagine your heart, all right, let's just first draw the heart here. This is our right atrium, left atrium, right ventricle, and left ventricle. And then you have our conduction system. Here's our sinus node, starts up there, and it comes down these internodal pathways to our AV node, splits off into the right side, the right bundle branch. We have our His bundle here too. And then our left bundle branch that splits into a left anterior and posterior fascicle. Okay, you also have a Bachman bundle that comes over to this left side. Now, when we talk about sinus rhythm, we're meaning that the rhythm is starting up here in the sinus node, okay, and it's heading this way. So in order to know if we're dealing with that, we're going to look at the P waves, okay, and we're going to see if those P waves are heading in this way, all right, and because that's where the mean electrical axis of that P wave is heading. So if you draw this out, we should have our normal P wave axis heading in this direction between 0 and positive 75 degrees. So within this region is where our normal P wave heads, okay? And if you were to put our leads on here, this is where lead 1 sits, this is lead 2, lead 3, lead AVF, okay? Then you can have V4, V5, V6, some of our precordial leads. AVR is here, all right? So just before we even get started, you can tell that if our P wave axis is heading in this direction, it would be positive in these leads, okay, all those here's, and then negative in AVR, okay. So let's look at what we have here. We'll look at lead 2, one of our inferior leads, okay. Again, a little hard to make out our P waves there. There's one there, you can see it. Okay, let's just erase so you can see that there. So there's a P wave, okay. Again, hard to make it out in 3, maybe one right there in AVF, okay. V1, can't really see, but how about those left lateral? Here's a P wave here, here's in V5, and there's one as well, okay, another one there. And then in AVR, here's lead AVR, we said it would be negative, and there's our negative P wave. Now a few other things in sinus rhythm that we see is that these P waves have to have similar morphology, meaning that they're not originating from some ectopic focus outside of the normal sinus node. And by doing so, we can tell by the normal P wave morphology as well as the upright P waves that we mentioned in those leads and the inverted one in AVR. Okay, now another thing of sinus rhythm is you want to see a P wave before each QRS, meaning that there's a 1-to-1 ratio. For each P wave, you see a QRS, okay? So let's do that here. Now you can see a slight P wave there, a QRS. There's another P wave and a QRS. P wave, QRS, P wave, QRS. And if you went through this whole thing, there's a P wave and QRS. Throughout the whole thing, there's a 1-to-1 ratio of one P wave for each QRS complex, okay? So because we met all those things, we do in fact have sinus rhythm here, okay? So regular rhythm, slow rate, right, below 60. Remember, our normal rate for adults is between 60 to 100 beats per minute, okay? And the rhythm origin is sinus. All right, how about atrial conduction? Well, typically we look at leads 2 and leads V1, okay? V1, which sits like right here, because it pretty much gives us a short axis view of both the right and left atrium, okay? So it's good for us to see if there's any atrial abnormalities. Now, as we said, it's a little hard to make out those P waves here, but they're certainly not prolonged or abnormally enlarged, right? They're already too small. So remember, the normal P wave duration is less than 120 milliseconds, so that's 3 small boxes, okay? So we have normal atrial conduction. Okay, if you look at our P waves, as we mentioned, all these you can slightly make them out, but they are certainly not prolonged and not enlarged in terms of amplitude. Now, how about our atrioventricular or AV conduction? Well, in this case, we are looking for any conduction delays as the impulse travels between the atria and ventricles. Because the majority of the PR interval represents AV nodal conduction, we're going to look there. The normal PR interval in adults is between 120 and 200 milliseconds. Okay, that's 3 to 5 small boxes. Now, just so you're aware, one small box represents 40 milliseconds. Okay, so 3 to 5 is 120 to 200 milliseconds. So we look at the PR interval and we can tell that it's normal here. Okay, so just so you're aware, when we look at PR interval, this is our P wave, our QRS, and our T wave, okay? Now our PR interval is from the beginning of the P wave up until the beginning of our QRS complex. That's what our PR interval is. That's not the PR segment. This is the PR segment from the end of the P wave up until that, okay? So when we look at AV nodal conduction, we're actually looking from this point up until that, the PR interval. And if you look here, we can see that, can erase some of this here, okay? Our P wave here, okay, if we look from here to there, it's actually less than 200 milliseconds, okay? So we actually have normal PR interval here. It was actually 152 milliseconds, okay? So that's considered normal. Now another lead we can kind of see that in, you can look here at V2, okay? Notice we have a P wave here and our QRS complex, okay? So if you took the time to pause the video, you can see that that is within normal limits, okay? It's actually 158, okay? So 158 milliseconds, still within that 120 to 200 millisecond range, so that's normal AV nodal conduction. Okay, next we have intraventricular conduction, or IV conduction, and here we're going to look at the duration of the QRS complexes, and the normal QRS interval is between 80 and 110 milliseconds, or 2 to 3 small boxes in adults. What we can see here is that we have narrow QRS complexes that are, again, within normal limits. So in fact, the QRS duration here was 92 milliseconds. Okay, remember we said normal is 80 to 110. So again, we have normal intraventricular conduction. Okay, so atrial conduction is normal, AV conduction is normal, IV conduction is normal. Okay, and again, just so you're aware, this is from the beginning of the QRS to the end. Okay, that should be 80 to 110 milliseconds. Now on to the waveforms. Now the P waves we said here were normal, so we can move on from that. Now the T waves are present, asymmetric, and appear normal. Generally the T wave amplitude decreases with age, okay, and it's slightly lower actually in women compared to men. And it's considered abnormal if it's less than 10% of the R wave amplitude, and we certainly don't have that here. Now the PR interval is not significantly depressed or elevated. The PR and QRS intervals we said were within normal limits. The ST segment does appear slightly elevated in those inferior leads 2, 3, and AVF, as well as in lead 3, V3. And there's no reciprocal changes that in those lateral leads that would suggest that there's maybe some ischemia present. So let's just look at that. I think that's something to note, and really one of the take-home message from here. Okay, so again, we're talking about the ST segment. Okay, the ST segment is this portion here. All right, between the QRS and T wave. And what we're noticing here is if we take this baseline, you can see that it's slightly elevated. Okay, same thing here. So that's in 2, 3, and you can see the same thing here in AVF. All right, slightly elevated there, as well as in V3. It seems like almost the most here in V3 as well. Okay, so those leads, you can see some slight ST elevation, and these ST elevation changes are actually considered benign in a normal finding in a young healthy adult, especially one that's young, healthy, and a male. Okay, it is called early repolarization, and we'll touch on this afterwards. I'll mention a few things. Okay, so again, that's the ST elevation. Now moving on, there's no ST depression present. Okay, and that's something important because, you know, ST depression is typically abnormal if we see it and tends to be a sign of ischemia. Okay, now the QT interval appears within normal limits. The QT here was 388 milliseconds, and the QTC, which is corrected for heart rate, was 377. Okay, so again, normally we want something below 460 milliseconds, so we're at normal here. So there are no major waveform abnormalities here, but we do have those ST elevation changes that we mentioned. So we're going to mention ST elevation, okay, in those inferior leads, 2, 3, AVF, okay, and we also mentioned in V3, okay, so that's one thing we have to note when we go back and go through our stuff. So is there anything else we're missing here? Well, not that I can see. If there's something I'm missing, please let me know, but the ventricular axis, that's something I want to go over too, is actually within normal limits, okay. Some people have trouble finding it, but I think once you know how, it's quite easy. There's normal R wave progression in the precordial leads, okay. Now what we mean by R wave progression, the R wave, which is present here, okay, you can see that it is progressing normally. It's hard to even make out these complexes, but what we should see is an R wave that increases from V1, V2, V3, V4, and V5, okay, as we move leftward across, okay, moving this way towards the left side of the heart, towards that left ventricle, the R wave amplitude should increase, okay. So you tend to see that, and we do see that here. All right. Now, one thing, there's also the baseline. It does seem to wander a bit here. Halfway through, you can see the EKG. You see that wandering. Notice here that how it's sloping down here. Okay, a little bit sloping down here, pretty much throughout this and up there. Okay, so that's what we call baseline wandering or wandering baseline. Okay, nothing too significant, but sometimes something to be aware of if you get quizzed on that. Okay, so let's look at that ventricular axis. That's something I want to make sure you know how to do. Again, nothing hard, but something that we can use, and if you know how to use it, can help you with your differential diagnosis. Okay, so if we do this, here's 0 degrees. Lead 1, the positive end sits there. AVF we'll use, the positive end sits down here at positive 90 degrees. This is plus or minus 180 degrees. This would be negative 90 degrees. So again, what we're doing here is looking at the QRS or ventricular axis. Okay, so what we do there, because it's the QRS axis, we're looking at the QRSs. So we're going to look at lead 1. Okay, hard to make out the QRSs here, okay, because they're pretty much sitting there. But they are positive, okay? And because they're positive, we head in this direction, all right, towards that positive end of lead 1. And if we look at lead AVF, here's lead AVF, okay? And lead AVF, you can see this is certainly positive, okay? So positive heading towards that bottom lead. So the axis sits in here. And if you recall what normal axis is in adults, it sits in this region, okay? This would be left axis deviation, right axis deviation, and this is considered extreme right axis deviation, sometimes known as no man's land. So we sit in this region here. Some people extend normal axis to be from negative 30 degrees to positive 105, but certainly if it sits within here, that's within normal limits, okay? And again, this is a 21-year-old male, so we usually use adult criteria with children if they're in the infancy or early stages. Remember, the right ventricle is the most dominant one early on in life, okay? Especially in utero, it's pretty much acting as the left ventricle. So you have the right ventricle is dominating, and you tend to sometimes see a rightward axis, so heading this way. But eventually, as we get older, it heads this way. Eventually, the older we get, always just heads pretty much in that direction, okay? So again, normal QRS axis or ventricular axis, and then normal R wave progression, okay? So hopefully that makes sense, and I just want to mention that wandering baseline that we have here, okay? So what's our final interpretation? Well, we have a regular sinus rhythm occurring at a borderline slow rate, right, at 57 beats per minute, with a normal intraventricular as well as atrioventricular conduction. There's no wave abnormalities other than that normal ST elevation finding in this young healthy male. So what we have here is a case of sinus bradycardia. Okay, so sinus bradycardia. Okay, all right, with benign early repolarization. Okay. And why do we say sinus bradycardia? Well, we have sinus rhythm, the rate's below 60, and again, those ST elevation changes that we mentioned are what we call early repolarization in these males that don't have any issues and are asymptomatic. This tends to be a benign finding. So now just a few points on early repolarization before we close. Okay, so sometimes this can confuse people, so let's go over it. So what you may find interesting in this early repolarization is that it really lacks a clear definition, and that's because there's not been any defined criteria for upper limits of ST elevation in young males with this normal male pattern. Okay, so it's considered a normal male pattern. So some have noted that there's common notching and slurring in the terminal portion of the QRS complex, and we can actually see that here. So if we erase that, that's something you'll note, is that there's this notching here, okay, that notching at the end of our QRS complex, okay, so you can see that there as well. All right, so you tend to see that notching and slurring. That's one thing that can help you lead towards that. And there have been reports that suggest that this pattern may be a possible predictor of enhanced aerobic fitness. Okay, so meaning those that have this may actually be in pretty good shape. Well, what's key here to note is that the slight ST elevation is present in most healthy individuals, especially males. In addition, the magnitude of ST elevation is often proportional to the amplitude of the QRS complex. In other words, the greater the QRS complex, the greater the ST elevation. Now, ST elevation is often the most prominent in the precordial leads, particularly leads V2 and V3. So V2, V3, okay? And it may be up to 0.3 millivolts or greater in these leads, okay? So 0.3 millivolts is simply 3 millimeters or 3 small boxes in these leads, okay? We said we saw it here in V3, not so much in V2, okay? Now, rarely does it exceed 0.1 millivolts or 1 millimeter in leads V5 or V6 or the limb leads. If it is present in the limb leads, which we saw in these inferior leads, okay, it will most often be seen in these leads. And these same leads are the ones that we saw that notching in. And this is because the ST vector in the frontal plane, if present, is directed inferiorly and often leftward in the direction of those inferior leads. Okay, so heading down this way towards, I remember lead 3 was here, lead 2, and lead AVF. Okay, so if it's heading that way, you have that vector, that's a depolarization vector, heading in that direction. Okay, so positive, and it makes, we see the positive, those ST elevation there in those inferior leads. Now, a few other things to note on our differential to consider would be acute myocardial ischemia and pericarditis, and that's where I said you would use that clinical context to help rule these out. Okay, obviously this is a healthy male, no issues, just comes in with this, okay? Now, one side note, the same of these things that we talked about for ST elevation do not hold true for ST depression. Now, ST depression up to 0.1 millivolts may be considered within normal limits in the limb leads, but any ST depression in the precordial leads is generally considered abnormal, as the ST vector in the horizontal plane is directed anteriorly and leftward. Okay, so just a little extra information for you, and hopefully it was helpful. Now back to finishing our case. So in conclusion, our 21-year-old healthy male student that visits our outpatient clinic has an EKG that shows sinus bradycardia with benign early repolarization. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. It helps us a lot and we really appreciate your support. Subscribe to the EKG Guy's YouTube channel for free access to more than 300 videos, including both pediatric and adult EKG courses. We're the largest, fastest growing EKG resource in the world.